I want to talk a little bit our approach to periocular rejuvenation, something I do quite a bit of and enjoy. By way of disclosures, I'm a trainer for Allergan and Galderma in the U.S., but I receive no financial support for this meeting. So aging in the periorbital area, like other areas, is insidious. It begins with a little bit of reduction of volume, reduction of highlight medially in the superior and inferior orbital rims, and extends laterally. So what you get is a reduction of the sort of double parallel line between the reflection of the subbrow skin and the lid margin, and that exposes the pretarsal upper lid skin. So you see more of the upper lid skin as well as more hollowing beneath the brow, and of course the tear trough formation. So I love this figure because it shows directly comparison between aged and youthful features in the periorbital area in particular. And these are subtle changes. These are millimeter, maybe two, but very subtle changes in volume. And as a result, we have to be equally subtle in our methods of addressing these. So one of the key things is we get increased shadow beneath the brow, and I think that creates a bit of an optical illusion that the brow has descended more than it really has. So I would submit to you that if you fill this side, it actually will create a bigger effect than elevating that side surgically, and because there may be about a millimeter drop in the height of the brow on this side, but the reduction of volume creates a larger perceived drop. The tail of the brow does tend to descend more than the medial portion, whether that's because the frontalis muscle does not insert on this side, subject to debate, or volume loss of the temporal region, whether that contributes much. But regardless, the tail of the brow does seem to descend typically more so than the central and medial portions, and as a result, that may be something that's more amenable to surgical lifting than the more central areas. In a more advanced scenario, you get more pseudoherniation, of course, of the lower lid, and more volume loss creates this double contour deformity, so-called, but creates a distinct separation between the lower lid area and the cheek, which we want to efface in order to create a youthful appearance. This, I would say, if this comes into your office in this scenario, would kind of stretch the limits of what we can achieve with synthetic fillers, but you can still get improvement. Just a reminder that the bony orbital rim atrophies as well, and as a result, you get expansion of the orbital rim. One of the key things from a surgical perspective is that means that if you're using the medial and lateral bony rim as your landmark for what the appropriate brow height should be, then you're going to continue to chase that superiorly into the forehead, and I think that's one of the reasons that brow lifts are overdone, excuse me. Likewise, this creates a loss of bony support, which then can be replaced with filling, whether it's with synthetic fillers, as in this talk, or fat transfer, which I enjoy doing as well. So if you then restore those highlights and recreate that double contour or double parallel line there between the reflection of the subbrow skin and the lid margin, it creates a more youthful appearance. And this is, of course, a doctored photo. She's not my patient, but you can see the light reflection improved in the supraorbital rim and the infraorbital rim regions. So this is my patient, and we actually published her in a paper that we did looking at the long-term retention of HA fillers in the tear trough area. And we showed about an 85% retention, volume retention at an average of 14 months. I will tell you that I have it beneath my own eyes, and I had it for 6 years before I had a touch-up. I could see with 3D imaging, we did vector imaging right before I had it touched up at 6 years, and that showed a retention of effect. It wasn't 100%, of course, but there was some retained effect at that point, and it's now been 9.5 years total, about 3.5 since the touch-up. So I think that's a nice effacement of the tear trough area and lateral infraorbital rim. This is probably greater than 6 years ago. My approach would probably be for a little bit more augmentation of the upper cheek at this point, but she was very happy. And this is not atypical where a patient comes in bothered by looking tired. And while she might want something done with the upper lids, and she actually subsequently did, in this case she wanted something non-surgical, and so that's what we addressed. So this is just the paper that we published on that. I do use cannulas, and I know Steve Diana, a recent talk that I was also discussed using 22 gauge cannulas only. I still use 27 gauge for the tear trough area, 25 for the more deep areas. I make a point of not hugging the orbital bone though, to avoid the vascular foramina and notches. Just keep in mind that they're not always foramina, but there can be notches, and so if you hug that orbital rim, then you may be directly going into a vessel. But the cannula use has really transformed my practice as far as reduction of bruising. Of course, it's not elimination of it. And actually, in this next patient, of course, when I was videoing her, I got a bruise, but I will tell you that overall, it's been a nice improvement. I have no financial affiliation with any of the companies that make these cannulas. So it's been a big improvement. And the reason that I really embraced them was because of doing the tear troughs, where otherwise with needles I would have frequently bruises that would last 2 weeks. And even with V-beam laser, it's just kind of cumbersome to work through. So just a typical, younger than probably most patients, but still, she's in her 20s and has grooves. And I will tell you that if you look at enough patients, if you haven't been doing so already, I mean, it can start quite young. I have a nephew who's less than 15, and he's going to be a setup for this kind of thing. So she naturally has a little bit less malar volume. And so just our technique a little bit. So I like to measure where the tip of the cannula will go, and then to the insertion site with a needle slightly larger cannula, or slightly larger size than the cannula. In this case, a 27 gauge cannula, so it's a 25 gauge needle. And particularly near the medial canthus, I like to stay fairly superficial for safety. And also, you're frequently not going to get much of an effect in the medial canthal area unless you go quite superficial. You should be safe from the angular vessel as long as you're at or lateral to the medial canthus. If you extend inferiorly, that's not true. So if you draw a vertical line straight down from here, then you're going to cross the angular vessel down here. So, but up here in the tear trough, that should be safe. Regardless, I'm injecting only on withdrawal. Sorry about that. And just to show that we then turn laterally, I'll try to go and get the lateral infraorbital rim from the same approach if a patient will permit it. Sometimes it's tolerable, sometimes it's not, and we'll extend then up to a more lateral approach, lateral infraorbital rim. And then lastly, what I'll show is sometimes this transition point between what you filled from this access point and the lateral point, just you can't quite get that last little transition to get what I think is a perfect blend from the lower lid to the cheek. And so a trick, if you haven't already tried this before, and maybe it's not necessary in your hands, but I found it necessary in certain cases where if I go through the malar mound, and you don't really see it so much in her, but you kind of get a feel for it after you've done a bunch of these. But in older patients, you definitely see the triangulation of the malar mound in this area. And if you go and make a needle stick sort of medially in that malar mound, that tends to give you a nice access into that transition point. That is a more likely area to give you Tyndall effect, though, and I certainly appreciate the use of Bellatero in that area if need be, but due to its monophasic effect. But I can tell you that you do still get Tyndall effect with that. It's probably less, but my filler of choice in this area is Restylane because it's predictable. It doesn't swell much, and I know the durability of it. So. And of course, there's the little bruise that she unfortunately got, of course, because I was videoing her. Not typical, but you'll have to take my word for that. And so then when we blend it into the cheek, just use that same access point. I may go a little bit lower, but always feeling with a non-dominant hand, obviously protecting the orbit and the globe, and injecting only on withdrawal. Extending laterally to get the lateral cheek. You can get most of it. Frequently, if I'm going to do lateral cheek, then I'll make another stick further out here in order to get that lateral zygoma. And so then extending to the supraorbital rim area, and again trying to efface the shadow there and trying to create the double parallel lines. This is a patient that we had just done her her right side, so left side of the screen here. We had filled that some, and this side had not been filled. And so just shows an improvement. And this is someone I actually had discussed doing an upper lid blepharoplasty, so she does still have some excess skin there. I don't try to fill everything so that there's no little flap of skin there, because you'll end up getting a bulged effect. So you just have to have a feel for what looks good without being overfilled. And then subsequently she's going to have an upper lid blepharoplasty. Thank you.